Hi, everyone. Welcome. My name is Lucy Schiffman. I'm the Senior Manager of Community Engagement for the Myotonic Dystrophy Foundation. Welcome to Genetics Unveiled, Understanding Testing, Counseling, and Family Conversations about DM1. I'm now really excited to introduce our speaker for today. Katelyn Payne earned her BS in biology and her AS in nursing from Purdue University in 2007. She worked as a pediatric nurse in Chicago for 2 years before moving here to Indianapolis to attend IUPUI's genetic counseling program. She graduated with her master's in genetic counseling in 2011 and spent the first 7 years of her career working in medical genetics and child neurology at Riley Hospital for Children. Since 2018, Katelyn has worked in adult neurology at Indiana University Health. She works specifically with patients with myotonic dystrophy through the Complex Care 6 clinic that is offered once a month to this patient population. She and her husband live here in Indianapolis with their 4 children. So now please join me in welcoming Katelyn Payne.
Thank you, everyone. I appreciate you having me today. My name is Katelyn. I live here in Indianapolis. I work for IU Health Neurology, and I'm going to be talking today about genetic testing in myotonic dystrophy type 1 with regard to understanding results and also family planning. I wanted to first just give an outline on the background of genetics in myotonic dystrophy, and then I'll talk about testing, what that looks like with regard to logistics, insurance coverage, barriers that may exist to testing, ethical considerations. When we think about results, what does that mean? Different variables that can play into results, and then anticipation. I'll also walk through a genetic counseling visit and what that looks like, how to consider sharing your test results with family members, and then how results can play into family planning. And lastly, we'll talk a little bit about research and clinical trial participation. So myotonic dystrophy type 1 is caused by a change in the DMPK gene, and that stands for dystrophia myotonica protein kinase. So this is a protein that's important in muscle, heart, and brain cell communication. There's a lot we know about this gene and a lot that we don't know. We also think that it plays a large role in the production and function of other proteins in the body. One example is that it plays a role in turning on and off an enzyme that's important in muscle contraction and relaxation. So we know that it does have other jobs, and people are working very hard to understand fully what this protein does, but I do feel like our knowledge right now is fairly limited. So myotonic dystrophy is considered a triplet repeat disorder, and I'm sure most of you have heard that term before. So thinking back to high school biology, you probably all remember DNA makes RNA that makes a protein. So we all have 2 copies of the DMPK gene, get 1 copy from mom, 1 from dad. And then within this gene is a region of DNA, 3 bases or letters of DNA, CTG, that are repeated over and over again. So a quote, normal number of repeats is considered between 5 and 34 repeats. And individuals with myotonic dystrophy would have anywhere from 50 to 5,000 repeats in that region of the DNA. So when the DNA makes the RNA, we know that the RNA is abnormal, mRNA or messenger RNA. And then when the protein is made, it doesn't fold correctly. And so that abnormal folding of the protein, it's not able to be recycled by the cell the way that it's supposed to. So it can clump or aggregate together in the cell. And eventually that buildup of that abnormal protein can become toxic to the cells and they don't work correctly. And so we know that happens differently in different tissue types across the body. And because that protein accumulation is happening over time, that's why some of these symptoms are progressive in nature, and we see things that are more difficult later in life than they are earlier in life. So making the diagnosis in myotonic dystrophy, this is a relatively well-known genetic condition, one of the more common ones that we see in our neuromuscular clinic. So before genetic testing was readily available, diagnoses were made through a few different ways. One is EMG Maybe many of you in this room have had an EMG before. That's the test where the neurologist sticks little needles in your muscle and looks at the electrical activity of the skeletal muscle. And in people with myotonic dystrophy, we can see something called myotonic discharges on that testing that may clue the clinician into a diagnosis. We can also look at another marker in the blood called CK, or creatinine kinase. This is an enzyme that is elevated in people with muscle weakness. So again, we can see elevations in people with myotonic dystrophy, especially with those that have more significant muscle weakness. And then lastly, a muscle biopsy. So this is an invasive procedure where someone's put under general anesthesia. A surgeon removes a small amount of muscle tissue, and then those muscle fibers are looked at under a microscope to see, is there any abnormalities there that again could point towards a diagnosis. So all of these things together, especially taken in the context of family history, is historically how these diagnoses were made. Now, the standard is genetic testing. So if family history is known, often we can skip all of these other 3 steps and genetic testing can be sent off, and it's straightforward. There's either an expansion in the DMPK gene or there's not. If family history is not known, an EMG may still be done, a serum CK may still be done, but we really try to avoid muscle biopsies because, like I said, they are invasive. They're also expensive. And they can tell us if the muscle fibers are abnormal, but they don't tell us why. So it's not specific to myotonic dystrophy. There can be abnormalities in the muscle tissue for a lot of different reasons. So it's really only done in cases that maybe have an atypical presentation or if genetic testing for some reason was inconclusive. But in general, we try to avoid muscle biopsies when we can. So, genetic testing, again, really the approach to genetic testing depends on the clinical presentation. If the family history is known or there's really high suspicion for myotonic dystrophy type 1, we would typically just look at the DMPK gene. If features are nonspecific, family history is unrevealing, clinicians may consider a broader myotonia panel. That could include the genes associated with myotonic dystrophy type 1, type 2, and other genetic causes of myotonia. Testing nowadays really is nearly 100% sensitive for expansions in the DMPK gene. So we should not miss any diagnoses with this testing. It's typically done on blood or saliva. I do think there are a few silver linings of COVID, and that is that a lot of genetic testing can now be done on cheek swabs, which just makes it that much more accessible to all of you. And in many states, Indiana included, we can see patients virtually. We can mail test kits out to people's homes. They're able to do the testing and send it back without ever leaving home. And that also, I think, is just a huge leap in another barrier previously to genetic testing. This testing does need to be ordered by a healthcare provider, and that really depends on somebody's presenting symptoms and who they're seeing for their care. So in some cases, that may be a cardiologist that orders the testing, a neurologist, a medical geneticist, and then in some states, genetic counselors can order genetic testing. One thing that we have seen on the provider side of things is that if clinicians are able to document how the genetic testing results are going to affect patient care, insurance is a lot more likely to cover the cost of it. We know there's cardiac complications in myotonic dystrophy. If your provider can write in their notes that these genetic test results will make a difference as far as surveillance recommendations, then that's huge in getting the testing covered. Insurance coverage certainly is different across different institutions. I can certainly speak to my personal experience that most of the genetic testing labs we are currently using are in network with Medicare and Medicaid. So patients that have those forms of insurance were usually able to do the genetic testing at no cost to them. Commercial insurance is where it gets a little bit more tricky. The lab may require a prior authorization. prior to sending the testing. But there are a lot of genetic testing companies nowadays that have online portals where you can submit or upload somebody's insurance information, and they can often give you an out-of-pocket cost estimate before they even do the testing so that patients understand what is the financial burden of this test. We have seen the cost of genetic testing just across the board come down significantly in the last 10 years or so. And a lot of labs will have out-of-pocket maxes for patients. So even if insurance denies the testing and ultimately doesn't cover it, patients can pay anywhere from $250 to $300, and they will cap that cost so that, again, it becomes more accessible to patients. And there's a lot of financial assistance programs that are offered by the genetic testing companies. Again, so that is not a barrier to people getting access to these tests, that they can provide household size, estimated annual income, those types of things, and then have a cost that's on a sliding scale. So don't let that be the reason to not do testing. There's definitely ways to work around the financial aspect of genetic testing. So I've talked a little bit about barriers. I do think cost and insurance has historically been a big reason why people have not pursued testing. And again, I do think we are making big strides here to make this more easily accessible to patients. I think there's also an aspect of unwanted information, especially in people who maybe a child is diagnosed and they have more mild symptoms, but that information can be hard to accept the diagnosis. And then also, I think sometimes there's the guilt of passing it on that certainly we just try to normalize for people. Nobody gets to pick what you pass on, right? Whether you have biological children or adopted, it's a lottery every time. So certainly, I do think that there can be power in knowledge about understanding who carries the gene change and who in the family may be at risk. So just trying to stress that to patients that there is a lot to be done if we know that somebody's at risk. And again, normalizing those feelings for people. And then lastly, the logistical barriers. So as I mentioned before, we can mail saliva kits. I know a lot of people who live 3 hours away from major medical facilities who don't want to travel just to have access to a genetic counselor or genetic testing. Hopefully, we can identify ways that people can be seen virtually and kits can be mailed to them. So I wanted to talk a little bit about ethical considerations with genetic testing. And the first is with regard to minors. So in general, and this isn't specific to myotonic dystrophy, but genetic testing as a whole, we try not to test minors for adult onset conditions if it's not going to change their care. So we want them to be adults, be able to make that decision autonomously about what they learn or do not learn about their own gene status. Certainly in a minor who is symptomatic, especially when there is a known family history of myotonic dystrophy, we would recommend testing because it is going to impact their care. And that's regardless of age. So I understand that it's different for each family, but again, just considering the age of the child, are there any symptoms present? And then is this test information going to be helpful, or is there any risk for psychological harm in testing a minor who is not yet symptomatic? And certainly, I think that's very situation specific. There's also concern for genetic discrimination, and we hear this a lot in our clinic. So I just wanted to touch a little bit on what laws are in place that protect people. So there is a federal law called GINA, and that stands for the Genetic Information Non-Discrimination Act. It was signed into law in 2008, and that protects individuals from discrimination in health insurance and employment based on genetic information. And what's included is family history information, genetic testing results, the use of any genetic counseling or genetic services, and then participation in research as well. So what's not included under GINA is life insurance and long-term care disability insurance. So in somebody who does not yet have a diagnosis of myotonic dystrophy but is considering testing, We would recommend getting those policies in place first before you test so that you ultimately don't have to disclose something that you don't feel comfortable with. Again, happy to talk through any of those logistics and how they may pertain to you, but that's the general recommendation for people considering genetic testing. So, in thinking about potential test results, there's 3 categories. On one end, there's positive. The expansion is greater than 50 repeats, and we would expect for those individuals, if they live long enough, they would eventually develop symptoms of myotonic dystrophy. On the other end, less than 34 repeats, negative, unaffected. And then in the middle is the gray zone, and this is the pre-mutation range. So people who have between 35 to 49 repeats, we would not expect them to have any symptoms of myotonic dystrophy, but we do know that the repeat size is unstable, and individuals with repeats in this region, it could expand when passed to the next generation. So there's risk to have children who are affected. So I do think that's an important consideration when testing. So I wanted to walk through our 3 categories of myotonic dystrophy. So at one end of the spectrum, we have mild DM1. These individuals usually have repeats between 50 to 150 CTGs, and symptoms typically include cataracts and mild myotonia. And myotonia is just difficulty relaxing the muscle after voluntary contraction. In the middle, we have classic myotonic dystrophy. These individuals usually have between 100 to 1,000 repeats, and symptoms can include muscle weakness, myotonia, cataracts, and then cardiac issues. And then on the severe end of the spectrum, we have individuals that can have congenital myotonic dystrophy. So these individuals usually have greater than 1,000 repeats in the gene, and they're typically diagnosed at birth due to low muscle tone. Sometimes you hear the term floppy babies. They have very little tone, and they can have a lot of respiratory complications, and they may require ventilation at birth. They may have some developmental delays or learning problems in childhood. And then as adults, they typically look like classic myotonic dystrophy. And I just want to say this slide certainly isn't encompassing of all symptoms that we know people with myotonic dystrophy can have, but I was just trying to outline the categories that we think about with this. So I do want to just mention what the repeat can and cannot tell us. So yes, it is helpful in knowing the repeat size because in general, a longer expansion is associated with earlier age of onset, more severe symptoms, and more progression as time goes on. However, there is no hard and fast rules. If you have 99 repeats, you're mild, and if you're at 100, you're classic, right? It's a spectrum, and there is certainly overlap between the 3 categories. So we cannot base our predictions of disease severity just on the repeat number alone. And another limitation of our knowledge is that some labs can tell you if the results are positive or negative, but they may not be able to give the specific repeat number depending on the technology that they use for the genetic testing. So some labs cap that at 200 repeats. So if you have more than 200 repeats, it's positive, but we don't know whether you have 300 or 800 repeats in the gene. And it may not matter, to be honest, because we're going to make our recommendations for treatment, management, surveillance the same, whether it's 300 or 800 repeats in the gene. So I think that becomes more of a personal decision if somebody wants to know their specific repeat number, but it may not change medical care. So all of this to say, the repeat number is important, but it is not the be-all, end-all of myotonic dystrophy, and there's a lot of nuances that go into genetic testing. I did want to run through some of those variables that can influence repeat number and disease severity. The first is that the repeat size may increase with age. So we know that CTG repeat is unstable during cell division, and typically we are only testing blood or saliva. And most people only have genetic testing once in their life. So there have been some studies looking at repeat size in childhood versus repeat size in adulthood, and we can see that number does get larger as people age. So that is one reason why we could see variability depending on when somebody is tested, at what time frame in life, and what is their severity of symptoms at that point. Another variable is that, again, the repeat size can differ depending on the tissue type. So I mentioned blood and saliva are pretty standard. We can also do genetic testing on skin and muscle tissue, but we don't usually go around biopsying other tissue types, right? So we don't look typically at cardiac muscle or brain tissue. So we don't know when we do genetic testing if that repeat number is representative across all tissue types. So that is a limitation when we give somebody their genetic testing results. And lastly, within that CTG repeat region, there can be interruptions. And what I mean by that is there can be insertions of letters of DNA that disrupt that expansion that influences disease severity as well. And that is something that we are typically not looking at when we send genetic testing to a lab. We do know that influences disease presentation, but it's not enough that we would include it as part of the test result. It's, again, just one of those nuances that gives variability that we can't account for. And one thing that I think about all the time is the DMPK gene is just one of your 23,000 genes, right? There's a lot of other things that make you who you are that we, again, don't know how all of those genes and their function interact with the DMPK protein. And so this is just one snapshot that makes up one part of really who someone fully is. I mentioned the term anticipation. So the definition of anticipation is that the repeat size can increase with each generation, and it's more likely to occur when maternally inherited. So it is not uncommon for us to have a baby who has low tone at birth, requires respiratory support. There is a genetics evaluation, baby's diagnosed with myotonic dystrophy, and then sequentially, mom is diagnosed. So that's pretty standard for us that we then realize, oh, wait, mom has some mild symptoms. We think she may have myotonic dystrophy as well. And then testing reveals a much smaller repeat number. And again, in those cases, mom may not have significant enough clinical features that ever really brought her to the attention of any provider. So it's usually in retrospect that we're identifying those moms. And then, of course, from there, it can be a cascade effect, right, where we identify aunts and uncles and grandparents as well because of this anticipation that occurs in myotonic dystrophy. So moving on to the genetic counseling visit. Many of you in this room may have seen a genetic counselor before. Genetic counselors can be embedded in all types of clinics. So we have genetic counselors that work in cardiology, neurology, medical genetics, prenatal as well. And every clinic functions a little bit differently as far as how they use genetic counselors. I know some clinics, they just utilize a genetic counselor services after results are in. For me, I'm typically involved with patients before they get tested and then after as well. So sometimes it is both, but a lot of our job is to get better access for patients to be able to have testing, again, with the insurance coverage. And then after results are back, being able to communicate those to people, allow them to ask questions, certainly, and then just provide education about what this looks like going forward. So there's two scenarios, I think, where we are helping individuals along, and that is either before the testing is done, trying to understand natural history, what that looks like, what are somebody's symptoms, when did symptoms start, how are they progressing, is there a known family history of any muscle disease, is it specifically myotonic dystrophy, or should we consider ordering like a broader neuromuscular disorders panel? And then when the diagnosis is known, providing education to these families. So again, myotonic dystrophy can affect every body system. I always tell patients it feels like my job to tell them everything that could possibly happen in this disease, with the caveat that not every person is going to have every single symptom on the list. But again, just allowing them to have access to all the information. Certainly, it's an ongoing relationship. It's impossible to think of all the questions that you have right after you receive results. But just making sure that patients know where to go when they do have questions. Who else should we consider testing in the family? And then long term, what's the prognosis? What should we be thinking about with surveillance, treatment, management, those types of questions? So I know some of you may be thinking, myotonic dystrophy runs in my family. I know I probably have it. Why should I get genetic testing? And I think that's a very valid question. I do think that we are seeing more people accessing testing because of the need of documentation of a diagnosis for insurance purposes. So again, all of that surveillance that I mentioned, thinking about cardiac screening, your insurance company may require that you have genetic testing in order to cover a lot of those routine echocardiograms, EKGs, things like that. I think other reasons people are interested in testing is because a confirmation of a genetic diagnosis allows access to research studies and clinical trial participation. So even in people who either are asymptomatic or mildly affected, they may think about testing because they want to be ready if and when, gene therapy becomes available or something along those lines. I also think it's important to determine who is at risk because it certainly affects, as I mentioned, the cascade testing. So thinking about first-degree relatives, children, siblings, parents, should anybody in those categories consider genetic testing? How does a genetic testing result influence relationships, family planning, and then future planning? So for some, it's just the anxiety of the unknown, right? I want to know my gene status so I can plan going forward. I've seen many individuals who are at the beginning of their career and thinking about going into fields that may require more physical activity than others. I saw a young man who was thinking about signing up for the Army, but really wanted to know, am I going to experience muscle weakness? And could this potentially slow me down from what my long-term goals are? And also along those lines, financial planning. I think that there's a lot that goes into considering genetic testing. And I think the reason our job exists is to help people think through positive results, negative results. What am I going to do with that information? And how is it going to be helpful to me right now? So along those lines, sharing your genetic testing results. And again, I realize that this is unique to each person in this room. So family dynamics are so different from each family. But I think, again, part of the genetic counseling visit includes just empowering people to be able to share their genetic testing result with close family members, because we know that early identification, early diagnosis is going to be really helpful in ensuring proper surveillance long term. And then I do think another one of our goals during a genetic counseling visit is that first degree relatives at least be referred for genetic counseling so that we can meet with people who are at risk, give them the information, and then allow them to make that decision autonomously. Is this something that they want to know? And are there any early symptoms that are already happening that maybe a genetic diagnosis can shed some light on? I was wondering why it was hard to walk up the stairs. I was wondering why I was having trouble getting up from a seated position, things along those lines. I think sometimes knowing the why behind things makes it easier to move forward. So moving on to family planning, I wanted to include just a couple slides about family planning because I did get a lot of background questions going into this talk. So really the optimal time for having a genetic risk discussion is before pregnancy. However, I realize that is not what's actually happening, right? A lot of times families don't even know this is a possibility when they're thinking about having a family. So one option that is available is pre-implantation genetic testing, or PGT. And so in families where there is an affected parent, this involves in vitro fertilization, so harvesting eggs, fertilizing embryos, testing embryos for the expansion in the DMPK gene, and then transferring embryos that are gene negative. So again, reducing the risk for children to be affected. There's a lot that goes into PGT. Certainly won't answer all of those questions right now, but just so that people know that this is an option that exists, and there's a lot more that goes into it that we can certainly discuss during the Q&A. I also will say, I realize that there's a lot of ethically charged feelings when it comes to reproduction, right? And so I do feel like our job is just, again, to let people know what their options are so that they, again, can make whatever decision is best for their family in these situations. So, as far as pregnancy, for babies that are affected with myotonic dystrophy, there may be some signs during pregnancy. So, yes, we can test during pregnancy. There's diagnostic testing available that can say, is baby affected or not? Again, that's a really personal decision. Some reasons why people will choose to test is because if baby's affected, it may change where or how they deliver. So, again, because of the risk of respiratory complications, they may want to deliver at a tertiary care center where there's a NICU readily available, that type of thing. As far as women who have carried babies that are affected, they may notice some decreased fetal movement, and there can also be increased amniotic fluid. And the term for that is polyhydramnios. And that's usually evident in the second and third trimester. We also know so pregnancy carries a risk for anyone, right? But for women with myotonic dystrophy, we know that there may be increased risk for either premature or prolonged labor and then a C-section as well. And it's probably because of muscle weakness in the pelvic girdle as to why there may be those complications. There is also some evidence for increased risk for retained placenta, placenta previa, and postpartum hemorrhage. From the medical standpoint, it would just be important if there is a risk for myotonic dystrophy, or if you know you're affected, just letting your OB know so that they can be monitoring for these potential complications. So the last thing I wanted to touch on is research and clinical trial participation. So in thinking about natural history studies, these are typically observational. There's no intervention, so it tracks the course of a disease in a population over time. And our goal is to understand how a disease develops, progresses, affects individuals, and really gain a comprehensive understanding of the disease's natural course. And it certainly helps inform research, drug development, and patient care overall. Clinical trials do involve intervention. And so this is a research study that tests how well new medical approaches work in people. The interventions can include medicine, procedures, devices on health-related outcomes, or they can look at the safety and effectiveness of new treatments, compare existing treatments, and then also explore new ways to deliver therapies. So I mentioned earlier that, again, a requirement of some of these studies are a confirmatory gene test. So we are seeing that positive result needed to enroll. And for that reason, more people are interested in having genetic testing for confirmation. So I do think research is an important area to at least briefly discuss. So where we are right now is that we don't know how to delay the onset of myotonic dystrophy. We don't know how to slow the progression, and we certainly don't know how to restore function that's been lost. And I would love to see all three of those things happen in our lifetime. And so I think the best tool that we can use is through research and clinical trial participation. I think all of you, even just being at this conference, are showing your interest in certainly advancing all of those things. So I just wanted to read a couple quotes here. Research and clinical trial participation potentially benefit both the individual and the broader myotonic dystrophy community by improving care and developing new treatments. So you may be asking, why participate? And we know that participants contribute to finding better solutions for care and may gain access to treatments that actually improve their overall health and quality of life. And then beyond that, individuals may choose to participate to contribute to scientific knowledge, advance understanding, or help find treatments for solutions for future generations, even if they won't directly benefit. And I hear that all the time. It's not going to make a difference for me, but when I think about my kids and grandkids, you can have all my time, all my energy, draw my blood, do whatever you need, because I'm here to help my kids and grandkids. And so I just wanted to end by saying thank you to all of you for just being here, helping further our knowledge. And with that, I can take any questions.
Question is, how do you find a genetic counselor or a place that can do the blood testing?
That is a great question. So I will refer you to a website called NSGC. It's the National Society of Genetic Counselors, and it's .org. nsgc.org. At the top of the page, you will see a little tab that says Find a Genetic Counselor. You can click on that tab, enter your zip code, and then choose how far you're willing to drive. 30 miles, 100 miles, and it will pull up genetic counselors in your area, and then different specialties as well who may be able to help you. And then also a lot of times it will tell you if they see patients in person, virtually, both.
So I hope I can frame this question. So many of us, we find out that the disease is in our family. And then of course we find that it's all through it. And then our children have it. Usually maybe it's our children that have it. So we know we have it in my case. And then can I make the assumption that my mom had it and my uncle, because my cousins have it? And how many generations back and how did it all of a sudden show up, or has it been there for centuries?
Yes. So I will say a lot of times, especially for older generations, it's like we know who had it without doing testing, right? We know genetic conditions have to start somewhere. So somewhere, someone had an expansion in the pre-mutation range. And then the next generation, it was 50 repeats. And then it was 75. And so that's true not only of myotonic dystrophy, but of other repeat expansion disorders, that it's probably not all from one person that we all descended from. It's probably from multiple individuals having this expansion just slowly increase with each generation.
Mine is about if you get pregnant, when can it be tested? The baby, right?
Yes. So diagnostic testing, they can do a CVS or chorionic villus sampling, usually between about 11 to 14 weeks gestation. And then the amniocentesis, I believe, is anywhere from 15 weeks on-ish is when the actual diagnostic testing can be done during pregnancy.
And so if I do not want to get natural, the PGT, is that 100% sure that they'll select to make sure that the baby doesn't have it?
I don't think anybody's going to tell you anything's 100%.
Well, no, I know.
It significantly reduces the likelihood of having an affected child. I will say it is my understanding they recommend repeat confirmatory testing after baby is born to say definitively unaffected. There's a significantly lesser chance.
I have a family member who did test 12 years ago and her repeats are at 12, but is now showing signs. Is there a chance that should she be retested? Because if there's the CTG is unstable as people age, it's now 12 years later and she's in her mid 40s.
She had a normal repeat number.
Yes.
And now she's showing signs.
Yes.
Okay. One thing that I didn't touch on in my talk is something called mosaicism. I don't know if anybody has come across this term, where you can have different repeats depending on the cell line. So in that case, they may want to, if they did blood 12 years ago,
yes.
they may want to consider doing a different tissue type this time and repeating testing to
Okay.
see if there is a level of mosaicism that was not identified. I've seen that happen before.
Okay.
But it would be unusual if you had a normal repeat size for that to then expand into the region of being affected.
Okay.
It's more that if it starts off expanded, it's unstable and can change throughout life.
Okay. It was my daughters who that we found out this from. My dad was diagnosed with an unknown neurological condition for 40 years of his life. We had him tested and his repeat was at the time 59.
Okay.
But significantly had issues later on in life. That's why I'm asking for her. Okay.
Yeah. So that's what I would recommend.
But with a different type. Thank you.
Mm-hmm.
Fortunately, I don't have any symptoms that I note of. I did have cataracts, so probably that. But as you get old, at what age can you say, I think I'm going to get through this? Or is there some age where, 80, 90, at some point you're just old?
I will say it is always difficult to differentiate what is just I'm getting older and what's myotonic dystrophy at some point, right? Because people that don't have myotonic dystrophy get cataracts. Yes, myotonic dystrophy is considered fully penetrant. And what I mean by that is people that do have a full expansion, we would expect, again, if they live long enough, they would have some degree of myotonia or muscle weakness, even if it's mild, even if it doesn't cause them any problems, really affect their quality of life. There's still something clinically that we can point to. So I don't know if there's a special age when you get to 85, if you haven't had any issues, you're in the clear. But again, it may be mild enough that it really doesn't feel all that significant.
Any more questions? Thank you so much, Katelyn,
you,
for
guys.
joining us.